evening and welcome everyone. It's so lovely to see you all here. On behalf of the Lamb Foundation, it is my pleasure to welcome you to this evening's Lambposium in Your Living Room educational webinar series. My name is Cindy Beasley and I am the Director of Education and Advocacy for the Foundation, and I will be your moderator this evening. So before we begin, I would like to take a moment to thank our generous sponsor, the National Disease Research Interchange, or NDRI. NDRI's partnership with the Lamb Foundation and Lamb patients has pushed forward the science of lamb through their coordination of lamb tissue procurement at the time of transplant. We appreciate their ongoing support of our research efforts and our educational programs. In keeping with that spirit of the power of lamb research and its amazing results that we've seen, it is my pleasure to introduce to you Dr. Rob Kotloff. Dr. Kotloff is Professor of Clinical Medicine and Co-Director of the Lamb Clinic at the University of Pennsylvania Medical Center. He has authored over 130 peer-reviewed articles, reviews, editorials, and book chapters, and has edited or co-edited 7 books and monographs. Dr. Kotloff was a founding member of the Penn Lung Transplant Program and has worked in the field of lung transplantation for over 30 years. In addition to his extensive experience in lung transplantation, Dr. Kotloff has special expertise in the evaluation and management of patients with interstitial lung disease, LAM, and other cystic lung diseases. He also maintains an active interest in general pulmonary medicine and in particular in evaluating patients with complex pulmonary disorders. So we're excited to have him here this evening, and I will turn this next part of our presentation over to him. Thank you.
Thank you, Cindy. Let me see if I can share my screen successfully here. Can you see my slides?
Yes, we can.
Okay. So I wanted to thank you for inviting me to speak tonight. I gave a similar talk, I think about 5 years ago, and was asked to update it. And there's actually a lot that's happened in the past 5 years. So really what I want to do is provide you with an overview of rapamycin, and you'll see in a minute why I subtitle this from fruit flies to Easter Island. So in terms of the goals of the talk, they are threefold. The first thing I want to do is pick up on something that Vera talked about and give you a little bit of a basic understanding of the genetics of lamb and how we came about choosing rapamycin as a potentially ideal drug to treat the disease. So in order to understand why we chose the drug, you need to understand a little bit about the biology of the disease. The second is we're going to focus on rapamycin and talk about its proven benefits and also the side effects that we've come to recognize as well. And the third is to talk about some lingering questions that have only partial answers at this point beyond what we learned with the MILES trial. So these are the 3 goals of the talk. And I'm going to start actually by giving you a little bit of a sense of the time frame of how things have unfolded here. So the first description of what we think was a patient with LAM was in the medical literature in 1919. It wasn't until about 50 years later that another article appeared that actually discussed more than a single patient. It's called a case series, and that just means that a physician or physicians were publishing a description of more than one patient with this disease. So over a 50-year period of time, we went from a single case report to a case series, but really no understanding of the disease itself. A major event occurred in 1995, and it had nothing to do with medical advances or basic science advances and everything to do with a very determined mother. What happened was that Andrea Burns, who's shown here back in an earlier picture, was diagnosed with LAM. She actually presented with pneumothoraces. And her mother took her to various academic medical centers only to be told that we really don't have an understanding of LAM. We think this is a uniformly progressive and lethal disorder. And in fact, what patients were being told at the time was that from diagnosis to death was 10 years. That wasn't necessarily true, but that was the understanding at the time. And Sue was also told that there was no treatment for this, that her daughter would just have to live and ultimately die with the disease. Well, there was no stopping Sue, and what she did along with her husband was started a Lamb Foundation and a grassroots effort to lobby Congress and lobby the NIH to study this disease. And that's where things really took off. So over the next 20 years, a registry was established at the NIH to record the progress of patients with LAM. So they would come twice a year to the NIH to be studied. There were major breakthroughs in the biology of the disease that I'm going to talk about. There were then 2 clinical trials. And by 2011, the first effective drug, rapamycin, had been identified. And several years later, FDA approval for rapamycin for treatment of LAM was achieved. So after a very prolonged period of silence where we had very little understanding of the disease, over a 20-year period starting in 1995, major advances. So now I do want to talk a little bit about the biology of this disease, and I'm going to do this in very simple terms. And you need to, in order to understand LAM, you need to understand that there are 2 different forms of the disease. There's so-called sporadic LAM, which occurs out of the blue. It's not inherited in any way, and it's not associated with any other underlying disease. But then there's a second form of LAM called TSC LAM, where the lung disease looks identical to LAM, but it occurs in the setting of a inherited genetic disorder called tuberous sclerosis complex. And this is a disease that can affect multiple organs, and it's characterized by the development of benign tumor growths in various organs called hamartomas. Well, the initial breakthroughs came with scientists who were studying TSC, not LAM per se. And in 1993 and 1997, the genes responsible for causing tuberous sclerosis complex were identified. But the mystery was still, even though we understood the genetic underpinning of that disease, we didn't understand why patients with sporadic LAM who didn't have TSC also developed LAM, until Lisa Henske in her laboratory found that those same mutations in TSC1 and TSC2, but this time acquired rather than inherited, occurred in individuals with sporadic LAM. So now we had a tie-in linking sporadic LAM and TSC LAM, both of those diseases sharing in common mutations in TSC1 and TSC2 genes. But then the question was, what do these genes do? And it really took a group of fruit fly biologists. They were working with a Drosophila, which is a fruit fly, to figure out what the TSC genes did. And what they did was they took fruit flies and they found mutated fruit flies where the TSC1 and TSC2 genes were no longer working. They were mutated. And they studied those flies that had these mutated genes that were no longer active. And what they found was, if you look at what I'm showing you here in this panel, this is a fruit fly eye, which actually is composed of little islets, all these little islets forming this complex eye. This is the normal fruit fly. But if you look at a fruit fly where the TSC1 and TSC2 genes have been inactivated by mutations, suddenly you see that there's excess growth in the eyes. These eyes are bizarre and enlarged. And what became clear was that these TSC genes were actually controlling cell growth. One final piece of the puzzle. And actually, before we get to the final piece, let me just show you what I mean here. So if we take a cell and we have TSC1 and TSC2 genes, they are actually working to keep growth in check, meaning you can think of the switch being turned off. However, if you inactivate the TSC1 and TSC2 genes, it flips the switch on, and then what happens is you get abnormal cell growth and proliferation. So this was the key to understanding LAM, whether TSC LAM or sporadic LAM. It had to do with a master switch that was being allowed to be switched on because the brakes, TSC1 and TSC2 genes, which were holding the growth in check, those genes were no longer working, so the switch is turned on. The last major advance came in 2001, 2002, and actually Vera Kromskaya was responsible for this in her laboratory. She mentioned this, and what she figured out was that this master switch was actually an intracellular protein called mTOR. So now we understand what TSC1 and TSC2 do. They're the brakes that keep the switch off. We understand that when they're inactivated, the switch is turned on, and we're going to call this switch mTOR. So the disease LAM is characterized by abnormal growth and proliferation of a certain cell called smooth muscle cells. And when these cells overgrow in the airways, the bronchial tubes, it blocks them and causes what's called airflow obstruction that we can measure with pulmonary function testing. When these cells overgrow in the lymphatics, it causes what's called chylous effusions, which are these milky fluid collections that can occur in the chest cavity surrounding the lung. When they overgrow in blood vessels, some individuals with LAM will experience what's called hemoptysis, or coughing up small amounts of blood. And finally, in the kidneys, the one manifestation outside the lungs, the overgrowth of smooth muscle cells causes this benign tumor called angiomyolipomas, or AMLs. Just to remind you, this is a characteristic appearance of what the lung looks like in an individual with LAM. You see all of these holes, or what we call cysts, that have developed in the lungs. And one thing I haven't explained to you is why the overgrowth of smooth muscle cells would actually cause these cysts. That's not totally clear, but there is at least one theory, which is that when these LAM cells overgrow, it's not the cells themselves that cause the cysts, but they secrete these digestive proteins. We're going to call them MMPs. And these digestive proteins actually cause destruction of the lung in the form of creating these holes or cysts. So it still all falls back on the notion that you have overgrowth of these smooth muscle cells. And this is just an image of what angiomyolipomas of the kidney look like. Here's a kidney here, and you see these dark spots. These dark spots are fat. Here's another kidney here, and you see these dark spots. Angiomyolipomas are characterized by fat-containing tumors, and we can tell just by their appearance on a CAT scan that an individual has an AML. This panel on the right shows the extreme example of an AML, where basically the entire kidney is now massive in size and is almost fully replaced by fat. This is an individual where you could actually feel the kidneys just by palpating the abdominal wall. That's how big the kidneys have become. So how does all this tie in with rapamycin? Well, let me tell you just real briefly the story of rapamycin. This is actually a naturally occurring substance. It's produced by a bacteria called Streptomyces hygroscopicus. And this bacteria was discovered on Easter Island, which you may or may not know is named by the indigenous population as Rapa Nui. Because the substance was identified on Easter Island, or Rapa Nui, it acquired the name rapamycin. That's where the Rapa comes from. And actually, it was initially developed because it had properties as an antifungal agent, meaning it was thought that this was going to be a drug that could treat fungal infections. But it was actually subsequently found to have immunosuppressive properties. It suppresses the immune system. And actually, it was initially FDA approved as an anti-rejection drug to treat or prevent organ rejection after solid organ transplant, like lung or liver or kidney transplant. But the mechanism of action of rapamycin is that it inhibits mTOR, and by inhibiting mTOR, it inhibits growth and division of cells. So I just told you that LAM is a disease characterized by, let me get to the next slide here, by dysregulation of mTOR, meaning that if you knock out these genes, TSC1 and TSC2, which is what characterizes LAM, then what it does is it flips this mTOR switch on and creates a situation where you have this unchecked and unregulated growth and proliferation of cells. But what rapamycin does is it turns that switch off. So it seems, at least in theory, to be the ideal drug to test to see if it works in LAM. And after some animal experiments suggested that, in fact, it would work, the first trial that was done in humans was not to study the effects of rapamycin on the lung, but to look to see if it would shrink AMLs of the kidney. The reason that was chosen was because kidneys are easily imaged, so you could get your answer very easily by doing a CAT scan before and after you treated the patient, and because it was thought that the effects would be relatively quick, so you wouldn't have to wait a year or 2 years or 5 years to see the effects. You could put a patient on the drug and then re-image them and see if there was a response. And I'm going to show you one example here. This is from the trial that was done, spearheaded in Cincinnati by Frank McCormick. And if you look at this kidney, here's the kidney here. You can see an arrow pointing to a dark spot here, and you can see an arrow pointing to a dark spot here. This is before the patient was treated with rapamycin. This is after. Here's the arrow pointing to the fact that there is no fatty tumor here anymore, and the same if we look at this arrow. So what has happened is that these tumors have regressed under the influence of rapamycin. So this was proof of concept that rapamycin seemed to hold that abnormal proliferation and cell growth in check. And this graph is just showing that during the time, this is showing a group of patients, each one is represented by a line, showing the size of their AML. During the time they were treated, you can see all the lines are slanting down because that meant that the size of the AMLs were decreasing. But you can also see that when rapamycin was stopped at 12 months, the lines start pointing up again because the tumors just regrew. So it drove home the point that the drug was only going to be effective as long as the individual was taking it. So that emboldened Frank and other clinicians and scientists to say, well, if it works on AMLs, let's see if it actually works on the lung, because that's really what we care about here. It's the lung that is potentially lethal in terms of the effects of the disease. So what was done was the so-called MILES trial. And it was a hard trial to enroll in. First of all, this is a rare disease, so there aren't a lot of individuals with the disease. The second issue was that because the drug was available even outside the trial, a lot of women were choosing to go on the drug rather than participate in the trial. So it really took a long time to get a number of very intrepid and bold and courageous women to enroll in this trial. And what was done, first of all, you had to have an FEV1, which is one of the markers we look at on pulmonary function testing. That marker had to be less than 70%. So we weren't looking at patients with very mild disease. We were looking at individuals who had pretty significant lung impairment to start with. And they were randomized to either get a placebo or to get rapamycin. And they were followed for a year. And what you could see during the treatment phase is that the placebo group, if we followed them along at the end of a year, they really weren't a lot different. I'm sorry, the placebo group is in white here. If you look at the placebo group, they had declined at 1 year compared to baseline. So the disease had progressed in the placebo group, whereas the group that got rapamycin, there was no difference at 1 year compared to when they started. So this looked like rapamycin effectively stabilized lung function, whereas those who were not on rapamycin experienced a decline in lung function. And just like the AMLs regrew when you stop the drug, we saw a similar effect here, that when you stop sirolimus, you then saw a decline in lung function that paralleled that of placebo, pointing out the fact that the drug was only beneficial during the time that it was being administered. This was a landmark trial because it was the first trial that showed that there was a drug that had the ability to stabilize lung function in patients with LAM. And what we've learned from the MILES trial and from some subsequent experience is that there are a number of now proven benefits of rapamycin. It stabilizes lung function in most, but not all patients. It shrinks AMLs. I showed you that information. What I didn't show you, but you need to know, is that it's also very effective in controlling and resolving chylous effusions, in resolving these abdominal cystic collections called lymphangioliomyomas, and in individuals with TSC who have these very red lesions on the face. Those regress when you use topical rapamycin, and it also causes shrinkage of these benign brain tumors that can develop in TSC patients called astrocytomas. So a number of very amazing and dramatic benefits to this drug. However, no drug comes without side effects. The most common side effect that individuals on RAPA experience are mouth ulcers that typically are intermittent but can be quite painful. I saw one of the questions from the community was, how do we treat it? And I think different physicians have different tricks to use. What I found to be most effective is actually topical forms of steroid, either as a mouthwash or as sort of a paste that you can put on the mouth ulcers, and that tends to promote healing much more quickly than if you didn't treat them. A second issue that comes up very commonly is that rapamycin elevates cholesterol. It has nothing to do with an individual's diet and everything to do with a direct effect of the drug on cholesterol metabolism. And a lot of women will develop elevated cholesterol levels. However, the knee-jerk reaction should not be to put that individual on a statin to lower the cholesterol, because most women, if you calculate their risk of cardiovascular disease, have a very low risk. And we only use a statin if we feel that that individual with the elevated cholesterol has a high risk of developing a heart problem or a stroke. And if they're at low risk, we will tolerate the high cholesterol levels without actually treating it. Two other very quick nuisance side effects. Some individuals can develop rashes that look very much like acne, and swelling of the ankles is another common side effect. I was asked about effects on gynecologic effects, and there are two effects that have been observed. And what we're looking at here, just to explain, this is actually from the MILES trial, and we're looking at the frequency of developing either irregular or absent menses. And you can see that in the placebo group, somewhere around 15% of individuals noted that, but in the group that received rapamycin, up to 50% of women experienced changes in their menses. The other gynecologic side effect that has been observed has been ovarian cysts. Again, if we compare the placebo group to the group that received rapamycin, a much higher incidence of ovarian cysts in the group receiving the drug. So we now recognize this as a side effect of the drug. There's a black box warning on rapamycin. In fact, if any of you open up the pamphlet that comes with rapamycin, you'd probably be scared off from taking it. But fortunately, most of the things that are described rarely occur. But I will mention that when we were using rapamycin as an anti-rejection drug after lung transplant, so we were starting it when we did a lung transplant, what was observed was that rapamycin impaired the ability of this connection, the bronchial tube connection that's done. It impaired the ability of that connection to heal, and these airways would fall away and what's called dehiscence. They would peel apart, and that would be a fatal complication. So basically, there's a black box warning that says this drug is not to be used in individuals undergoing lung transplant, at least until that airway has healed. And just quickly, what that has meant was initially, when lung transplant programs put patients with LAM on the wait list, they would tell them to stop their rapamycin. Now, since waiting times can be 1 year and beyond, that's not such a good thing, because now you have a year where that patient is no longer on Rapa and can experience accelerated decline in lung function. What we've since come to accept is that if we stop Rapa at the time of transplant, and I'm showing you on this little graph here, the Rapa levels will rapidly decline such that by about 6 days out, those levels are undetectable, and that's the critical healing phase for that airway. So we now feel it's perfectly acceptable to stop Rapa at the time of transplant rather than stopping it at the time a patient is put on the waiting list. Some programs insist on switching patients to everolimus while they're on the waiting list, simply because that drug washes out much more quickly when you stop it than does rapamycin. But the point is, a transplant program should no longer be telling an individual that they have to stop the drug at the time that they're listed. Now, that's a unique situation to individuals who are waiting transplant, but there's a more general concern that you need to be aware of, which is that any patient on rapamycin who is having major surgery has to stop the drug. If it's elective surgery, you stop it a week or two before. If it's emergent surgery, you stop it the day of the surgery, because rapamycin impairs wound healing. And if you continue the drug after major surgery, you run the risk that the surgical wounds will not heal properly. Other side effects, I don't want to take up too much time here, but you're going to read or hear about two very serious side effects, or one other serious side effect. The first was wound healing. The other is called pneumonitis, which is paradoxically an inflammation of the lungs that that can result from taking the drug. This is a CAT scan. And what I just want to show you here, this happens not to be a patient with LAM, but you can see that there are light and dark areas. The dark areas are normal lung. The light areas are portions of lung that have been flooded with inflammatory cells. And this is what rapamycin looks like. The point here that you need to understand is that if you're on rapamycin and you develop a prolonged cough and fever, that's something that your clinician, your caregivers need to know about, because they would want to image you with a chest x-ray or a CAT scan. And if there was evidence of pneumonitis, they would have to immediately stop the drug and put you on prednisone to relieve the inflammation. Fortunately, this has proven to be exceedingly uncommon in the LAM population. Finally, I mentioned to you that Rapa was initially FDA approved as an immunosuppressive drug to prevent organ rejection after lung transplant. So if we suppress the immune system, aren't we going to see a lot of infections as side effects? And it ends up that hasn't been the case, that when Rapa is used alone, as opposed to an organ transplant patient who's on 3 immunosuppressive drugs, if you just use Rapa alone, we have not detected a signal of increased infection rates between, and in the MILES trial, for example, there was no difference between the treatment and the placebo group in terms of incidence of infections. So you do not have to worry about being vulnerable to infections when you're on rapamycin. There are a whole host of drug interactions that can occur with rapamycin. So anytime anybody wants to put you on an additional drug, it's wise to run that by your LAM clinician. I've listed a number of drugs that interact, but I'm going to mention 2 interactions. One is not a drug, but it's grapefruit juice. And if you're on Rapa, you should have been told that you should not drink grapefruit juice. You can drink any other citrus drink you want, but for some reason, grapefruit juice markedly elevates rapamycin levels in the bloodstream. The other that has become very relevant is that if you develop COVID and your physician wants to put you on Paxlovid, there's a very strong interaction between Paxlovid and Rapa, such that the Rapa has to be held during the 5 days that you are on Paxlovid. And I typically tell patients for an additional 5 days after they stop Paxlovid to continue to hold Rapa. So just to summarize, and then I will very quickly go through some questions that are only partially answered, but to date, there are numerous proven benefits of rapamycin. It's really been a major advance in the treatment of this disease that previously had no treatment. And despite many potential side effects, it's generally well tolerated. Importantly, we tend to use much lower doses than were used in the MILES trials, so we're seeing far fewer side effects than were previously reported. It does still require that you have periodic blood tests to monitor blood levels, lipid profiles, blood counts, and liver function. So let's very quickly move to some questions that were posed to me that are only partially answered at this point. The first is, are the benefits of rapamycin on lung function sustained? So I showed you that the MILES trial only went out 1 year. So what happens 3, 4, 5 years out, or 10 years out, or in a lifetime of rapamycin? And we're starting to get some insight into that from something called the MIDAS registry, which was started by the LAM Foundation, which is a registry where any patient with LAM can agree to be part of the registry. And we're simply tracking individuals, their lung function, complications, side effects, et cetera, and breaking them into those patients who are on mTOR inhibitors, rapamycin, versus those who are not. This was given to me by Nishant Gupta. This is some unpublished data looking at the MIDAS registry, and this is tracking lung function in patients not on mTOR inhibitors and those who are on mTOR inhibitors. And quite honestly, I can't tell the difference when I look at it this way. But when I present the data like this, which is saying if you're not on Rapa, what's the average change in FEV1 over per year versus if you are on Rapa? And you can see if you're not on rapamycin, those individuals over a 4, 5, 6 year period tended to lose around 75 cc's per year of lung function, whereas those on rapamycin, now being followed 4, 5, 6 years out, had sustained stability of their lung function. So this is giving us at least a partial glimpse suggesting that the effects of rapamycin are sustained. We obviously need much more data to be more definitive in that conclusion. Another question that was posed is, what's the impact of rapamycin on survival in patients with LAM? You would think that if we can stabilize lung function, or at the very least slow progression, that we would see improved survival. And this is a study that coming from a registry in China, where they looked at 164 patients with LAM who were on not receiving rapamycin, and they looked at about 400 patients who were on rapamycin. And you have to understand that these are not identical groups. In fact, the group that was on rapamycin had worse lung function than the group that wasn't on rapamycin. That makes sense. You're not going to start rapamycin on patients who have well-preserved lung function. And even though the group on rapamycin had worse lung function, their survival was still significantly better. If you look out here at 8 years, survival was much better in the group being treated than the group that was not being treated. So again, a partially answered question that suggests that the administration of rapamycin actually improves survival. Should rapamycin be started earlier? I wish I could give you an answer here, and hopefully we will have an answer. The MILES trial, the trial that showed benefit, did not enroll patients who had normal lung function or even near normal lung function. You had to have an FEV1 of less than 70% to get into the trial. So that trial looked at patients who had very significant lung disease. The question is, well, if we start the drug even earlier, will that prevent patients from progressing to the point where they're down to 70% or below? And what that led to was the so-called MILD trial, which has had a challenging time enrolling, but has finally completed enrollment. And what this trial is intended to answer is, if we take patients who have extremely mild disease and we start them on just 1 milligram of rapamycin, will those patients do better than a similar group of patients who are not started on the drug? So it is a placebo-controlled drug, meaning half the patients get rapa, half the patients get placebo. They're going to be followed for a year to see if there's any difference in the trajectory of their lung function, to try to answer the question of whether we should be starting rapamycin at a much earlier time point. I'm going to skip this just for the sake of time and answer, or attempt to answer, a question that comes up all the time. So I've mentioned that rapamycin in general will stabilize lung function in individuals with LAM, but we've also encountered a number of individuals who progress despite being on rapamycin. And our knee-jerk reaction as clinicians is to say, well, let's just bump up the level. If you're on 1 milligram and your level is 4, let's go to 2 milligrams and push your level up to 8, your blood level. And maybe that will be more effective. It ends up, and there's not a lot of data yet, but there is one study that came out from Britain, and I'm just going to quote the conclusion. There was no association between change in FEV1 and serum rapamycin level. Our findings would be consistent with the idea that serum levels of greater than 2 are sufficient to treat progressive lung disease in most women with LAM. So this is some very preliminary data, and it actually reinforces my experience, which is that the only thing you get out of pushing rapamycin levels to higher levels is side effects. There's not a lot of data that you get more benefit at higher levels than you do at lower levels. A new indication for rapamycin is in women who have had recurrent pneumothoraces. There is some data, and I'm going to just quickly show you 2 studies that suggested that women who were experiencing pneumothoraces, not responding to conventional therapy with a pleurodesis procedure, if you put them on rapamycin, it seems to diminish the likelihood of developing another pneumothorax. So I'm going to show you first, this is one study where this is a group of patients who, if we start here, they had their initial pneumothorax, and over time, there's my pointer, over 5 years, the frequency of recurrent pneumothoraces was over 50% in this group. So more than half of the patients experienced a recurrent pneumothorax after the initial one, whereas if after the initial pneumothorax patients were put on rapamycin, the recurrence rate was only about 10%. That's one study. This is a second study. This is really just a case series of 5 different patients who were described. The blue dot is their first pneumothorax. The red dots signify recurrent pneumothoraces. So, for example, this patient, after an initial pneumothorax, had 5 recurrences, but then once started on sirolimus, those recurrences stopped. The only time that recurrences were seen, there were 2 patients who had recurrences, one because they stopped taking their rapamycin, and the other because they were started on drugs that reduced the level of rapamycin in their bloodstream to undetectable levels. So it's as if the rapamycin was stopped. In those 2 cases, pneumothoraces recurred, but in all the other cases, no recurrence. So we are starting to use rapamycin to diminish the risk of pneumothorax, although this is by no means fully proven yet. I'm going to run through the rest of the slides because I do want to give you a couple minutes for other questions, but hopefully I'm answering a number of your questions with these slides. A question that has come up, particularly during the COVID period, was if rapamycin is immunosuppressive, isn't it going to affect my response to vaccines? Isn't it going to blunt the response to vaccines? And paradoxically, it does not. This is just one such study proving that. These are individuals who got 2 doses of the COVID vaccine, and then they had antibodies measured. So after the COVID vaccines, you're supposed to mount a detectable antibody response. And if you look at the control group of individuals, most of them mounted a response. There were 5 individuals who had very flat responses. If you looked at the rapamycin or sirolimus group, it was virtually identical. So the notion that rapamycin impairs vaccine response rates has been disproven, and there is absolutely no reason to interrupt the administration of rapamycin before getting vaccinated. Another common question that comes up is, if I'm on rapamycin, is that going to increase my risk if I get COVID that I'm going to have a serious infection? This is the only study I'm aware of that tried to answer that. This was a study where they looked internationally and identified 99 individuals with LAM who had developed COVID infections. And they broke that down into the group that was on rapamycin and the group that was not on rapamycin. And you have to keep in mind, these were not equivalent groups. If you're on rapamycin, that likely means you have more severe disease than individuals not on rapamycin. And you can see by the FEV1 lung function that if you were being treated with rapamycin, your average lung function was around 66% of normal. If you weren't on rapamycin, you were likely to have normal lung function. But if you look down further, what we learned was if you develop COVID and you're on rapamycin, you are much more likely to end up in the hospital. 43% of those individuals hospitalized versus 19% not. But it's not clear that that's because you were on rapamycin. It's more likely that you started out with very abnormal lung function and now took a hit from COVID and that landed you in the hospital. But if we look at more serious outcomes, like the need to go on a ventilator, there was no difference. There were only 2 patients in the RAPA group who required a ventilator, and there was only 1 patient out of 47 who died in the RAPA group compared to no patients in the Sirolimus group. This is not statistically significant. So the take-home message here is that, yes, patients on rapamycin who get COVID are more likely to end up with serious infections, probably not because of the rapamycin, and probably much more likely because they have compromised lung function starting out. The last point I'm going to make, and then I'm going to conclude here, is something that Vera commented on, which is, I'm going to go back to my little model here showing you that TSC and TSC1 and TSC2 basically put the brakes on mTOR and keep that switch off. But if TSC1 and TSC2 are not working, which is what happens with LAM, the brake is released and the switch goes on and you get this unchecked cell growth and proliferation. And we talked about if we add rapamycin, that would flip the switch back off. But it ends up that it actually doesn't completely flip the switch off. And I would think of it more as it dims the switch rather than it completely shuts off the pathway, as Vera showed you. And why is that? It ends up that there are actually 2 switches. There's this mTOR binding site that rapamycin binds to. That's one switch. But there's a second binding site that also is involved in shutting down the mTOR pathway. And if we just use rapamycin, we're only turning one switch off. These new so-called bisteric mTOR inhibitors are these drugs that have been manufactured to bind not only to the RAPA site, but to the second site. And by binding to both of these sites simultaneously, they turn both switches off, and they seem to be much more effective in shutting down the mTOR pathway than using RAPA alone. So what are we going to see in the near future? We're likely going to see clinical trials, first in cancer, because cancer is also under the influence of mTOR. So there are going to be cancer trials using these drugs, and then likely we will see a trial in lamb to see if it's more effective than rapamycin. I've gone over my time here. I just thought I would end with a little bit of a smile here, which is rapamycin has caught on in the general population. You may or may not be aware that there are studies that show that it seems to be an anti-aging agent. This has nothing to do with lamb. There's a book that's been on the New York Times bestseller list for almost a year now. He actually advocates that all of us should be taking rapamycin if we want to slow down our aging process. And I was actually somewhat disappointed to see that you can now go on a internet site and sign up without a physician consent. You pay your $150 and they will ship you rapamycin, in this case called, I think it's Ageless RX, as a way to slow down your aging. So rapamycin is caught on not only in the lamb community, but we might be putting it in the water supply so we can all live to be 200 years of age. I'm going to stop there, and I apologize for going over. I don't know if we have time for questions or not.
Yes, no worries. Thank you, Dr. Kotloff. This has been so interesting, and I especially appreciate all the updates. You've addressed some really important questions for our community. So I do have a few. We'll give about 10 minutes here for some Q&A. I have questions that were submitted in advance that I'll begin with. The chat box is open right now. If you want to go ahead and submit there, we'll get to as many as we can, but I do want to allow for time for our group discussion as well. So the first question we have is, and this really just has to go to the manufacturer of sirolimus. This comes up over and over again. Should I be concerned about the manufacturer for sirolimus, and how can I be sure my generic is safe and effective to use?
That's a tough question to answer. I can tell you we've been through this a lot with, for example, medications that we give to our transplant patients. The anti-rejection medicines all started out as brand name, and then they transitioned to generics. And a lot of patients were very concerned about switching. The best I can tell you is that the one thing we need to do is repeat blood levels once the switch is made to make sure you're achieving the same blood level with the generic that you are with the brand name Rapamycin. As to the quality of the drug, these drugs are regulated by the FDA, and they have to be very similar in their behavior to the brand name. So I would hope that with FDA scrutiny, that the generics that we deal with in this country are as good as the brand names.
Great. So that's a great solution to that, is checking those trough levels. Thank you. And then how long does it take for sirolimus to begin working in the body and for the side effects to begin? Is this an immediate thing that happens to patients typically, or does this happen over time? Have you seen anything with that?
So when you say how long it takes for it to work, it depends on what you're asking it to do. So if you're asking sirolimus, rapamycin, you're not actually asking the drug. But if you're looking for an effect on AMLs of the kidney, you can actually start to see that effect within about 6 months. If you're looking for effects on lung function, basically you're looking over several years to see if it's actually changing the slope of what was previously decline in lung function. So that's certainly not an immediate effect. The only relatively immediate effect I know of is with chylous pleural effusions. Usually within several weeks of starting rapamycin, those effusions will dry up. In terms of side effects, they can occur, for example, mouth ulcers can occur within days to weeks of starting the drug. Once you have a therapeutic level in the bloodstream, you can start to experience side effects.
Great, thank you. I've got one here in the chat box that says, are there any thoughts regarding postmenopausal women continuing with rapamycin? Do we look at hormones and its impact with rapamycin or not?
So I don't want to give the wrong answer here, because I know, for example, Nishant Gupta has been very interested in the interplay between menopause and lamb, but I will make one observation that came out from the Miles trial and from others as well, which is that for individuals who are experiencing decline in lung function, that decline clearly slows after menopause. And these are untreated individuals. So menopause, as estrogen levels drop precipitously after menopause, that also results in slowing of the disease. As to whether you should stop RAPA after menopause, that's a question that I really don't want to answer, except to say that I don't think that's anybody's practice right now.
Right, thank you. You also mentioned some of the typical side effects that are there. There have been some rumors out there in the lamb community that rapamycin may cause mental decline. And there was a study that someone had sirolimus-induced toxic optic neuropathy. How fearful should we be of these side effect rumors, if you are, that are out there? And is there a way for us to determine whether those are really legit? I'm not sure how to approach this as a lamb patient.
So first of all, I'd be interested to see the what sounds like a case report of optic neuritis or some sort of optic complication. The best I can tell you is that first of all, the Miles trial gave us insight into what the more common side effects are. And since that time, the registries that are being kept are also looking at side effects. The side effect that you mentioned, the two, mental decline and optic complication, are two side effects I have not encountered and have not seen in the literature. So if they do occur, I suspect they are exceedingly rare.
Okay, thank you. And then some people have severe problems with GI issues. Do you have any recommendation for anybody who's on sirolimus that might have GI issues?
I'd have to know a little bit more. So diarrhea, for example, might be one thing that can occur, and usually something as simple as taking Imodium can help with that. The other point I would make about this is that we are using far lower dosing of sirolimus or RAPA than we were in the past. So many individuals are just on 1 milligram of rapamycin daily. And on that dose, we are seeing far fewer side effects. So if you are having side effects on the drug and you're on a higher dose, you may want to talk to your caregiver about whether the dose could be adjusted and dropped a bit.
Great, thank you. And then has there ever been any discussion, or is there any availability of sirolimus through an inhaler or through another way to take it besides orally?
So I know there's a company that a couple of years ago had approached me and others in the lamb community about a clinical trial of an inhaled form of sirolimus. I don't know what happened with that trial, but I can tell you my concern with the trial would be whether you get adequate penetrance into the lung tissue itself. We tried this with lung transplant. There's a immunosuppressive drug called cyclosporin that was the main drug we used to prevent rejection after lung transplant. And a company came up with the idea of, rather than giving it by pill where we get all these side effects, why not just inhale it and see if we can get the same outcomes? Not that you want to extrapolate from one situation to another, but that proved to be a negative trial. It was not effective. And my concern with any inhaled drug is that it gives you very high concentrations in the bronchial tubes, but not necessarily in the lung itself, the meat of the lung. And I worry that it would not have the effect that you would desire in terms of decreasing proliferation of the smooth muscle cells.
Okay, thank you. And then I know you covered this somewhat in your talk, but this is a question that comes up a lot. Can you explain to us, is there any difference between everolimus and sirolimus? Let's just reinforce this. And is one better than the other? Is there any time that someone would be recommended to be on everolimus as opposed to sirolimus? There's some confusion about that.
So sirolimus is the drug of choice in the United States. It was the drug that was tested in the Miles trial, and it's the drug that we have the most experience with. Everolimus is a close cousin. It works in the same way. It's an mTOR inhibitor, and it's a little bit more popular in Europe and outside the States than it is here in this country. And there's a little less experience with it, but the clinical trials that have been done with everolimus suggest that it is as effective as sirolimus. So in terms of benefit, I don't have major concerns. I would just say that we have much more experience with sirolimus. The one advantage to everolimus that I'm aware of is that it has a shorter half-life. And that means that if you stop the drug, it takes less time for it to wash out than if you're on sirolimus. So for example, if you're having surgery getting back to that transplant issue, why do we switch patients from sirolimus to everolimus if they're waiting for a lung transplant? Because if they're on everolimus, the drug will wash out in about 3 days. If they're on sirolimus, it can take 6 days or even up to 10 days to get all the drug out of their bloodstream. So the only real advantage I'm aware of is the short half-life of everolimus.
Okay, great. Thank you. And then do you know whatever happened to the study that combined Rapa and resveratrol? Will
I
anything
don't
come of that or yeah.
I don't know if Vera, if you're aware, that was a clinical trial, but I never heard any results of that.
Right. And yes. All right. You mentioned that grapefruit is to be avoided. Are there any other foods or supplements that we should avoid when taking sirolimus?
No, the only food substance would be grapefruit juice. The one other food that you'll hear about with lamb in general that has gotten a bad reputation is soy products. I don't know if our community is aware of that, but soy products have an estrogen-like substance in them. So there is some concern that if you're someone who's a tofu addict, that you can potentially be taking in the equivalent of exogenous estrogen, and that's to be avoided. But anything in moderation. So it doesn't mean you can't have soy products. It just means you shouldn't have excessive soy in your diet.
Okay, great. Well, I noticed that we have a lot of questions in our chat box and we don't have as much time as I'd love to have. So I have asked one of my associates to go ahead and save those questions. I will gather those, see what common themes we have. I'll consult with Dr. Kotloff and try to get back to you. Each of you, your names are on here, so I will try and do my best to get those answers for you all. So I want to thank you both. Thank you, Dr. Krumskaya. Thank you, Dr. Kotloff, for being here this evening. You all have created such informative and engaging presentations for us on a topic that is so important to us, both the future of research for LAM and also the ongoing continuance of our use of sirolimus. So thank you so much. I'm going to let you all go back and enjoy your evening. For the rest of you who want to, actually, first of all, let's give a round of applause if you can. I know that's tough on Zoom, but for our speakers, we greatly appreciate your time and all that you did to inform us this evening. So at this time, we are going to go ahead and stop the recording of our webinar. This will be available on our website. So if there are pieces that you missed,